Hello, everybody. Our discussion today is about basic medical principles. We're just gonna go through um, kind of some housekeeping things and with safety standards, we're gonna chat about taking a history and physical exam, and then some different testing modalities that can be used to evaluate our patients further. I know a lot of this is going to be review for you guys, but we want to make sure that we're on the same page moving forward. So just to start off, some topics about disease transmission. The Occupational Safety and Health Administration, or OSHA, sets standards to protect healthcare workers and their patients. It's important that we stay within these standards to help protect ourselves. Specifically, bloodborne pathogen standards covers anybody that could be exposed to infectious waste. So it's important to think about this not just when you're working with patients, but afterwards as well. The most important thing you can do for yourself is wear gloves whenever there's any question about contamination. Okay. Other things that you need to be have available to you would be face and eye protection, gowns, and then mouthpieces in case you need to perform rescue breathing. Box 1-2 goes through how do you handle infectious waste. And then it's also really important to make sure that you're removing all of this personal protective equipment appropriately. The last thing you want to do is take all that time to protect yourself and then just contaminate yourself upon removal. So going through how do we appropriately disinfect surfaces, box 1-4 goes into the mandates by OSHA on disinfectant agents. Important to note that contaminated surfaces, they must be sprayed to saturation with the disinfectant. And that amount of time that it needs to sit there really varies depending on different pathogens. HIV only takes about 30 seconds to kill. Hepatitis B virus takes about 10 minutes. So just important to keep in mind that it's not just a quick wipe down. So standards of care, you can refer to the National Athletic Trainers Association Code of Ethics for what your guys' specific level of care is, but it's considered negligence when you fall below what would be considered kind of standard medical practice. And then not only do you have to fall below that, but you also that negligence would need to result in physical or mental harm or damage to another. So referrals are going to be a big topic for us throughout this course. Um, I kind of use the phrase here that it's important that we stay in our lane. Okay, and this is to say that we need to focus on not just what we've been trained to do, but also what we do often. Okay. Just as a brief example, I'm a family medicine nurse practitioner. I've been trained how to reduce shoulder dislocations, but I don't do them often enough that I am the one that should be doing that. If you're not doing something often enough to maintain your competency, then you're not the appropriate person to be performing that therapy. And it's important to note that if you do delay an appropriate referral, that can result in lasting damage or potentially death. So it's important that we know our own limitations, not just of our licensure, but also of our competency within our licensure. Once again, the NATA Code of Ethics mandates that you refer injured athletes for further medical attention. And not only do you want to place the referral when it's indicated, but you also need to go to the right place. So that's going to be a big topic for us moving forward. Important to talk a little bit about medical records. We need to store them in a secure way. And the purpose of your documentation is really for your own protection, as well as to communicate with other healthcare providers. So you want to document thoroughly enough that if there's ever an issue of litigation or suspected negligence, that you can go back and talk your way through what occurred in those situations. Speaking more about being able to communicate with other medical directors or medical providers, um, there's a lot of different coding standards that go into medical records, such as the International Classification of Disease. We are currently on ICD-10. I think your book has ICD-9 examples in there. But these codes are pretty generic. They can be either really generic or really specific, and they are updated often. For instance, there's already an ICD-10 code for falling from a stack of milk crates because of the milk crate challenge. So they update them pretty often. And then the current procedural terminology or CPT codes are a good way to communicate between providers what procedures were performed. A big thing when you are placing those referrals and speaking with other providers is making sure you speak the language. It adds an awful lot of credibility to you and to your practice if you're able to use appropriate medical terminology and understand it. So Appendix A has common medical abbreviations for you to review, and Table 1-1 goes through common medical terminology. HIPAA is something we'll just briefly chat about. It essentially protects healthcare information, making sure that we're not sharing with media, coaches, or even parents if the patient is over 18, and that any inappropriate disclosure without express permission is illegal. And then FERPA is what protects the privacy of student education records and limits that disclosure as well. So the pre-participation examination, or what's most commonly known as the sports physical, determines the readiness for a specific sport and identifies any potential or correctable conditions that may impair the athlete's ability to fully perform. I know you guys have done these and have been tested on these as well, but important to note that ideally this would take place at least 6 weeks before the onset of the sports season, because if we were to find something abnormal, that would give us enough time to do further testing and evaluation. So setting the stage for that comprehensive physical exam or that sports physical, you want to make sure that you do the behind the scenes work to give you a good exam, such as picking a good time and place for both you and the patient in order to maximize that time. You want to focus on your verbal versus nonverbal communication. Make sure you're maintaining good eye contact with open posture. Steer away from closed-ended questions as much as possible. Those are those yes or no questions we all tend to kind of fall into. Open-ended would be more, can you tell me more about that? How would you describe this? Those kinds of things. Make sure you always summarize what the patient told you. This is a good opportunity to make sure that you understood them correctly and let them know that you were listening to them. Throughout this course, we're going to be talking a lot about signs and symptoms of various conditions. So just to start out with some definitions. A sign is any objective finding, such as a blood pressure or a degree of pupil dilation. Symptoms would be more something that your patient tells you, such as that, like a headache or nausea. So we're going to talk about the history taking of a chief complaint. You can use this as part of your comprehensive exam or just every day when somebody comes in to be seen or if they're injured on the field. So the extent to which you take a history varies in length depending on how urgent their condition is, okay? So we're talking right now that nothing super urgent is going on. Patient isn't in respiratory distress or anything that requires us to go a lot faster. So old carts and news is kind of a framework to try to help make sure you don't miss any steps in your history taking. So old carts is to evaluate that acute problem. So you ask about, okay, when did this start? Where exactly are your symptoms? Duration, is this all the time? Does it come and go? The characteristics of the symptom, is it sharp, dull, achy, burning? kind of how would they describe it to us. And then aggravators, like what makes the symptoms worse, and then what makes it better. What treatments have you tried, and then the severity of their symptoms. News is a framework in order for you to understand how is this really affecting the patient's function, because it's not enough just to know a good diagnosis, but how are they dealing with it. So nutrition, you can go through like a 24-hour recall, but oftentimes it's enough to know, like, are they still eating well? Are they hydrating well? Those kinds of things. Elimination, you can talk about like bowel or bladder function at this point in time, but often I kind of go into emotions with this, like how are they really coping with it? Have they had to miss work or school at all? And is this symptom affecting their sleep? Once again, your history continues. You can go into their past medical history, childhood and adult illnesses, any surgeries, go into their social history, alcohol, drug, tobacco use. Are they up to date on their immunizations? And then you can dive into their family history as well. So then you progress into your review of systems. And this review of systems is like the goal is to help broaden your gaze. It can be really easy to kind of zero in on a certain system, such as, let's talk a little bit about like chronic cough. So it could be really easy to, my patients here with chronic cough, to just talk about, you know, their lungs, do they have a history of asthma, are they a smoker, that kind of thing. But one of the big causes of chronic cough is actually reflux disease. And so the review of systems is used to help us get that information, because your patient might not think to tell you, oh yeah, I've actually been taking, you know, Tums 5-6 times a day to help with my reflux. So it's important that you always ask the constitutional symptoms, such as fever, chills, fatigue, night sweats, malaise, or recent unintentional weight changes. Okay, this helps you know whether this is kind of a systemic problem or if it's more localized. And then at a minimum, you always need to talk about the system above and the system below. So in the chronic cough example, it'd be important to talk about like head, ears, nose, throat symptoms, as well as GI symptoms. So the comprehensive physical exam, very first thing you need to do is just that general survey. And this helps you determine how fast you need to go. And I know you guys have already been tested on this, but like I said, we're just going to kind of fly through this to make sure that we're all on the same page as we move forward in this course. So obviously, if your patient is, you know, in respiratory distress and their airways compromised, you're not going to be, you know, going through their range of motions and such. So you really got to make sure you get good at that first general survey. And start with those vital signs to make sure that there isn't anything grossly abnormal to start with, and then do their skin and then go head to toe. Okay. Vital signs, you guys are all pretty versed at that. We'll go through specifically as we go through the different systems and problems that could go with this, why it's so important to check these and what that information actually tells us. Just a brief example. So as I said in my intro, I worked advanced heart failure and cardiac transplant. And it's important that we check people's blood pressure every single time because unless we check it, it can be kind of deceiving. I had a patient who was had pretty severe heart failure and came into the hospital just for a routine thing, and we checked their blood pressure, and it turns out that her blood pressure was I think in the high 60s, so maybe 68/45, and she was walking around doing just fine. Okay, so that's a pretty dramatic example, but at that level of blood pressure, she's not getting enough perfusion to her organs. But because it had been kind of a chronic issue for her, she was able to adapt to it and didn't have any symptoms of, you know, dizziness, lightheadedness, that kind of thing. So it's important to check it every time because you never know when those things is gonna pop up. And important to keep in mind, the sixth vital sign is pain. So your assessment Um, Auscultation is gone through a little bit more in table 2-6. Make sure that you're pointing, the earpiece is to your nose or you won't hear anything. Make sure your tubing is free. You're not accidentally like rubbing it on your hand as you listen, because then you'll get really funny sounds. Your order of assessment is inspection, palpation, percussion, and then auscultation, except for the GI tract. You always want to auscultate first, because once you start pushing on it, you can actually change the bowel tones and such. Inspection, this starts right away, as we said, with that general survey, and even as you conduct your history, you're noticing things such as, is the patient diaphoretic? Are they short of breath? Those kinds of things. And the best way that to really get in on this is just to practice. You can be performing some of these things, even in the grocery store. Try to get good at your observational skills and really noticing more of those smaller details. Palpation, important to create a pattern so that you don't miss any spots. You're assessing for a whole bunch of different things, such as their skin, temperature, is there any crepitus, that kind of thing. I put the degrees of like the depth for light versus deep palpation, not like I expect you to really measure, but to think about, light palpation is more on the surface and deep palpation is you're really diving down in there. Percussion is used to assess sounds transmitted through organs and cavities. And once again, this is one that you need to do an awful lot to get good at. Direct percussion is when you directly tap on the patient, versus indirect is most of the time I put my hand like on their abdomen is where I do percussion the most, and then I use my other hand to tap on my finger itself, and that gives me that indirect percussion. Different tools that you could use during your physical examination. I'd be surprised if there's a lot of indications for you guys to be, using an otoscope and such, but those are possibilities. Neurologic testing, cranial nerves examination for head injuries, but if you're examining cranial nerves, you really need to be thinking about referring out. Cranial nerve 1 is often skipped. That's, olfactory. Deep tendon reflexes, involuntary motor reaction to that stimulus. Dermatomes on the right, here's the different pictures of the dermatomes. So if people are having symptoms along a specific dermatome, that could indicate, help us figure out where the problem is. Some further diagnostics that might be done. X-rays are, used probably most often. And the X-ray beam is absorbed to different extents by different body tissues. So when you get the image from the X-ray, tissues that are less dense will appear dark, and tissues with higher density will appear white. And it's important to note that you often get multiple different views to get a full picture of whatever it is you're X-raying, because one view just takes a 3D object and obviously makes it two-dimensional. So you need multiple different views in order to try to create this three-dimensional idea. A couple of considerations. Pregnancy, obviously every time somebody is getting x-rayed, we need to evaluate for pregnancy, as the radiation could be damaging to the unborn child. And more images, so the more we x-ray somebody, the higher their risk of leukemia and melanomas. So radionuclide bone scan, it's essentially they inject this radioactive particle into the bloodstream that then emits gamma rays that's attracted to areas with increased metabolic activity. They inject it, wait between 30 minutes to 2 hours. And then areas of inflammation or injury to a bone will appear dark and are then called hot spots. And this can be used to identify stress fractures, bone infections, bone cancer, and arthritis. We're going through these not because I expect you to be able to order them or even interpret them, but if somebody is going for these and they have some questions, I just want you to have a kind of base familiarity of what it is. A couple of considerations, people, if they're allergic to red dye, this isn't a good procedure for them. Once again, pregnancy, the pregnancy risk with the radiation. Important for the patient to drink lots and lots of water afterwards to help flush out that radioactive nucleotide. And then the half-life is only a couple of hours, so even the next day, all of that radiation is gone. Fluoroscopy, this is a live image to determine size, shape, and movement of tissues. This is used more often in athletic training because it's a quick, non-invasive procedure that you can do with your patient in the weight-bearing position. And you can use it to determine if a fracture has occurred, but it can also look at blood flow, tumors, fractures, organs, foreign bodies, and some soft tissue. I've included a link to a YouTube here that is pretty cool. That's of a fluoroscopy of the coronary arteries. A CT scan, just like an X-ray, but helps provide that 3D image that the X-ray lacks. And so it passes rotating beams of X-ray through the patient and measures transmission at a bunch of different points. Like I said, 10 to 100 times the radiation of an X-ray. Sometimes it's used with contrast, which can be damaging to the kidneys, so that's something we need to keep in mind. And it's most often reported in cross sections. MRIs uses magnets to align all the body's atoms in the body. And then when that magnet is turned off, those atoms generate radio waves that are at different frequency depending on the location and chemical environment of the atoms. And the computer picks that up and is able to create that image. MRIs are a lot better at tumors, musculoskeletal injuries, soft tissues. Calcium and bone don't show up really well on MRI. No documented side effects. Claustrophobia is a big consideration with this because it's a pretty tight machine. And MRIs are also really expensive. So that's an important consideration in order to get insurance to pay for them. Ultrasound, super common, no documented side effects. Used to identify tumors in large lymph nodes, heart abnormalities, soft tissue injury, bleeding, and fetal development. Nerve conduction studies and electromyography used to evaluate nerve damage. They essentially put needles in different muscle groups and record that electrical activity, and it presents back with a waveform. And then electrocardiography, that's just like your typical EKG. You'll hear the difference between EKG and ECG, and there isn't any difference. Electrodes are placed on different parts of the body in order to provide different views of the heart's electrical activity. And that can be used to help identify, ischemia, heart attacks, pericarditis, valve problems, electrolyte imbalances, as well as other issues. This is just an example of the different placements for those EKG leads, and each dot or each lead is used because it gives you a different view of the heart to make sure you're not missing any. Holter monitors is essentially an EKG that people wear for between 24 hours to a month. Cardiac stress testing is just, ECGs done during exercise. If we're not able to stress somebody's heart enough with exercise, they'll use medications. Laparoscopy is a procedure where a small incision is made to view the inside of the abdomen. They insert a little bit of air in order to allow the organs to separate from the abdominal wall. Other laboratory tests, UAs are probably one of the more commons that you'll use. Box 3-2 goes through conditions a UA may reveal. You can actually find out a lot about a person's body based on a UA. You can evaluate for UTI, diabetes, liver problems, kidney problems. A CBC, or a complete blood count, is that microscopic review of a blood sample, tests for anemia, infection, inflammation, different red blood cells and white blood cell markers. Pulse ox measures the amount of oxygen in a person's blood, helps to determine if they need supplemental oxygen. Your book states that the normal range is, anywhere from 95 to 100%. And values below 95 indicate varying levels of hypoxia. These numbers here would maybe be up for a little bit of debate. We really don't get super worked up until until your pulse ox is below 90. But then again, if you have a 20-year-old healthy patient, there isn't a lot of reason that they really should be even less than 95. So a big part of interpreting that depends on the population you're working with.